Good morning. First off, I would like to thank AIOS for giving me this opportunity to present my topic.
His laptop. We have put the timer on.
Okay.
Yes.
So
yes.
before managing any case of trauma, it's best to strategize before getting into the OT. Best way to avoid your burnt fingers. So for a long-term advantage, always strategize and plan. Traumatic cataracts in pediatric age group can present as a feature of a closed or open globe trauma. In these, often we have corneal involvement. So whenever there's corneal involvement, first we'll have to close or do the sutures or corneal tear repair. So anterior lens capsule can present with either a breach or, and whenever there's an immediate presentation, we should plan for a corneal tear repair with lens aspiration. For IOL implantation, we usually do a secondary IOL implantation at a later date. Where the presentation is delayed or where ALC is intact, we can plan for a lens aspiration IOL implantation together. There's a paper, and we all know that OTS or ocular trauma score is a useful prognostic tool in trauma and traumatic cataracts for adults. There's another paper from Dr. Shah et al. Which says that it can also be used for pediatric trauma and gives good prognostic, is a good prognostic tool there as well. And the paper further highlights that open and closed trauma situations are different and should manage differently. And the time interval is also a very important determinant factor for final acuity. So IOL power calculation in these cases, wherever there's a corneal tear, we have to do the corneal tear repair. Remove the suture after 6 weeks, wait for 2 more weeks, and if there are no reliable findings, we can use the topographic guided method or the contact lens method. So where do we place the IOL? If the capsular bag is intact, in the placement with a single piece IOL is the best. When there's no capsular bag, when there's a capsular support, so in the sulcus, a 3-piece IOL can be placed, and no capsular support, SF IOL or glued IOL. Another paper which says that the iris fixated or the scleral fixated IOL gives similar results. Even in long-term pigment dispersion results are compared. So associated iris traumas, if there's anterior synechia or posterior synechia, we can release with spatula under viscoelastics. Iridodialysis, we can use a double arm McKennel suture. Sphincter tears, pupilloplasty. Another paper which says the final outcome is depends on the type of cataract, and it says the white softer cataracts have better prognosis than the hard ones. So fight the battle smartly. Some tips for winning. VR backup, whenever you have that feeling, always take a VR backup. K reading, we've already discussed about that. So there's a video which says we saw lens matter already in ALC breach. The first thing is to aspirate the loose cortex. Second is to stain the capsule with trypan blue. Third, make it a uniform enlarged opening. After that, we proceed as normal pediatric cataract. We do lens aspiration. Do a PPC, anterior vitrectomy, and place the single-piece IOL in the bag. So PPC is done, anterior vitrectomy is done. And then we inject the 3-piece into the bag, and we take sutures. So another few tips. Use the ILM peeling forceps for better control and capsular management. Go to the suspected area of PC dehiscence last in irrigation aspiration. Always remember to do an indirect ophthalmoscopy before you make a PPC and IOL implantation to rule out any infections. When planning a secondary IOL, do make a PPC in younger children and convert your PC plaques and PCRs to a PPC. Another paper which says we should always prefer to make a PPC in traumatic pediatric cataract, and it's essential. So IOL placements as per the capsular bag support, and we've already discussed about the IOL placements. Another video which talks about expect the unexpected with a traumatic cataract. Yeah, while doing lens aspiration, we suddenly noticed the PC is gaping. We did the lens aspiration, anterior vitrectomy, and we made the PC opening into a uniform PPC, placed a single piece IOL into the bag, and then sutured. So more the iris handling, the more the inflammation. A stitch in time saves 9. Better to stitch than leave a micro leak, because it's a pediatric cataract and will be under anesthesia. So there's another traumatic case where we had a non-dilating iris with Sine key. We used iris hooks to expose. We made a anterior capsular opening. We used the ILM peeling forceps for that. Then we used a vitrector to clear the visual axis, do lens aspiration. And after that, we made a primary posterior capsular rhexis and placed a 3-piece IOL into the bag. Using a vitrector, we had to do a PPC because there was a thick PC plaque right in the center. So post-op, very important, steroids, mandatory antibiotics and cycloplegic to reduce the pain. In secondary IOLs, you can always plan. One important point I want to highlight before I finish, that amblyopia management is a must. That's something that all cataract surgeons may have a little difficulty with.
Thank you.